Good evening, friends, and welcome to this wonderful program on the respiratory physiotherapy. This is going to be a very interesting and very knowledgeable session. I'm very sure for that. Today's our guest is Dr. Sweetie Shah. Dr. Sweetie Shah, we all know she is a very well-known physiotherapist for all of us. She has done her graduation and post-graduation from Government Physiotherapy College of Ahmedabad. She has done her PhD from Gujarat University. She is a certified aerobic fitness trainer. She is certified nutritionist. She is certified BLS and ACLS trainer. She has done MPT and PhD. She is MPT and PhD guide at Gujarat University. Uh, have given guest lecture in various conferences, published more than 25 research papers in various national and international journals. She has done number of on-air FM and television programs for awareness of physiotherapy profession. She has contributed for our profession like anything. Importance of specifically for the importance of cardiopulmonary in physiotherapy. She has done a lot of awareness programs for the same. She has given expert opinion on occasion of World Health Day, Orange Alert program, and she is COVID-19 pandemic. In this recent pandemic, she is playing a vital role in strategizing the war against the pandemic. Specifically the role of the physiotherapy. Right now, she is faculty at SBB Physiotherapy College, VS Hospital, Ahmedabad. She is having about 20 years of experience in the field of physiotherapy. Thank you very much, Dr. Sweetie Shah, for joining us. Thank you so much, and it's our pleasure and privilege that you are going to give us this knowledgeable session to all of us. I would like welcome, madam.
Good evening, everyone. Thank you, Dr. Neeraj Bansali, sir, for such kind words and a generous introduction. It's really a pleasure and an honor to be on this platform, especially on this special day, Ekta Divas today, as we all know it's very important for all of us as an Indian, the birth anniversary of Sardar Vallabhbhai Patel, the Iron Man of India, was said so because of his strong willpower. So, greetings of the day to everyone. Uh, just to share a brief story about his childhood, and probably most of us will be aware of it, but it's important to share because of today's day and the today's topic, that is on pain. When Sardar was very young, he had a boil in his armpit, and which was full of pus, which was not getting resolved because of despite most of the treatment. And so someone suggested to hit it with a heated iron rod on it to get rid of it. And because of his willpower, he did so and get rid of this. This story narrates his strong and daring character. But if we relate to our today's topic of pain, it tells us about the pain perception. That because of strong personality, he could withstand that unbearable pain. So it also leads us to the fact that pain is a subjective phenomenon. The perception of it varies from person to person. It not only depends on the noxious stimuli. And if we go precisely into the topic of the respiratory pain, it is little bit different than the other encountered pain. So there are a number of factors affecting pain, which we'll go into detail of it and how they affect the respiratory pathology in patients.
Yeah, wonderful, ma'am. Thank you very much for such beginning. Friends, I would like to welcome Dr. Paras Bura also. He is a key person who, because of his efforts, we are in a position to arrange this wonderful program. Dr. Paras Bura sir is a faculty at Leeds Physiotherapy College, Baroda. Thank you very much, Paras sir, for to be helpful for arranging this wonderful program. Thank you so much and welcome to the program. Sir, few words from your side.
Thank you so much, sir. This is in this uh, COVID-19 pandemic situation. This is one of the very important topic, and this is very untouched topic. That's why I was very curious to have a webinar on this. And thank you so much, Neeraj Bansali, sir, for providing this platform for learning and teaching methodology in this COVID-19 situations. And my best wishes to Sweetie ma'am and Neeraj Bansali, Team Spinex team. Thank you so much.
Thank
Thank
you.
you,
Thank you
Dr.
very much,
Paras.
sir. Thank you.
Thank you, Dr. Neeraj.
Yeah, Dr. Sweetie,
And so
the
begin
platform
with
is yours now. Thank you so much.
thank you so much. Thank you.
Yeah.
Let's start.
Yeah, ma'am. You can start your program. Thank you.
So, as we all know, that pain is an unpleasant, distressing feeling, often caused by intense or damaging stimuli. No one likes pain of whatever cause. The International Association for the Study of Pains, that is IASP, defines it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Here, the important factor is that it is also a sensory and an emotional experience which is associated with maybe actual or potential tissue damage. The definition has been revised in this year 2020 that an unpleasant sensory and emotional experience associated with or resembling that associated with. So it may not be associated with, but it may resemble to be that actual or potential tissue damage. So the revised definition has few keynotes which says that pain is always a personal experience which is influenced to varying degrees by biological, psychological, and social factors. The second point to be emphasized on is that pain and nociception are different. They cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected, even if it is not conventional. Although pain usually serves as an adaptive role, it may have an adverse effects on function and social and psychological well-being. Verbal description is only one of the several behaviors to express pain, but one has to remember that inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. The types we all know. It can be a physical pain when it is caused by damage to body tissues, when something hurts on the body, described either as throbbing, aching, burning, etc. Psychological pain, which is a pain caused or increased or prolonged by mental, emotional, and behavioral factors like depression and anxiety. Headache, back pain, stomach ache are common examples. We all would have experienced such type of pain at least during the exams or just before an exam or when we are in an apprehension or in an anxiety state. We have backache or headache with no physical component, right? The intensity, this scale describes 0 to 10 with no pain, 0 describing no pain, and 10 describing the worst pain one can ever tolerate. It can also be classified as mild, moderate, or severe if it has an intensity of less than or equal to 4, 5 to 6, or greater than or equal to 7 out of 10, respectively. The duration, according to the duration, it can be classified as either acute pain, which if it's lasts between 3 to 6 months, chronic pain, if it's 6 months or more or persisting beyond the cause of acute disease, or after tissue healing is complete. So not only the calendar months of 6 months, but if it persists after the acute cause is resolved or after the healing has occurred, still the pain persists, then also it is a chronic pain. And acute on chronic pain, that is acute pain flare superimposed on underlying chronic pain. If we come to our today's topic of pain in respiratory pathology, it usually originates from either musculoskeletal, pleural, systemic, or tracheal inflammation, because one has to note that lung parenchyma and small airways do not contain pain fiber innervation. So whatever is the pain coming in the respiratory pathology, it is either from a musculoskeletal, pleural, systemic, or tracheal cause. It's not from lung, neither from the small airways. We all know that any respiratory pathology is grossly classified either as obstructive, which includes COPD, chronic obstructive pulmonary disease, asthma, etc., and restrictive, which includes pleural conditions, tumors, kyphoscoliosis, etc. Now, we talk something about the COPD, the obstructive component, and how it affects the pain. It's a major health burden worldwide. It's estimated to be the third leading cause of death by 2020. It has multisystemic effects, which includes peripheral muscle dysfunction, malnutrition, right heart disease, depression, decreased exercise tolerance, etc. It's characterized by exertional dyspnea, fatigue, anxiety, decreased exercise tolerance, decreased health related quality of life. But above all these symptoms, pain is the most common and most severe symptom in COPD patient, but unfortunately, it is the most neglected symptoms also. People talk about fatigue, people talk about dyspnea, people talk about coughing, but this patient mostly from pain and in a more severe form, but in a different way, which is often neglected. Its prevalence ranges from 44 to 88 percentage, which a number of studies have concluded that. So the prevalence is quite high. The vicious COPD circle. The circle is related to pain and breathlessness. Both these symptoms reinforce each other and are not easy to live with simultaneously. Most patients are unable to identify or differentiate whether pain is actually a cause or an effect of frequent chronic breathlessness. So they do not know what is causing what, but they suffer both simultaneously. These patients describe their pain as tying up their body, making it impossible to breathe, which in turn resulted into increased pain. So difficulty to breathe further aggravates the pain. This suggests the sensation of pain and respiratory systems may be related to each other. The reference. Fear and anxiety are also associated with pain exacerbating activities. So there is avoidance of physical activity, which leads to reduction of muscle flexibility, strength, and endurance, leading to a downward spiral of increased disability. So you can see in this the vicious circle, COPD causing dyspnea, lack of exercise, limited mobility, which leads to social isolation, the pathology itself and the social isolation, this we all have facing these days because of the pandemic, the lockdown and all, how it affects our overall personality, causing the depression, which further aggravates the dyspnea and the vicious circle goes on. Is there association between pain and dyspnea, psychological symptoms, and health related quality of life? Of course, yes, there is a strong relation or strong correlation between these symptoms. Increased pain intensity has been associated with pain catastrophizing, which is an exaggerated negative cognitive and emotional response to actual as well as anticipated pain. A person feels all type of negative worst feeling that he cannot be any more worse than the present situation, though his condition may not be as bad as he thinks of, but the response is so exaggerated. There's increased pain severity leading to poorer health related quality of life, obviously. They both, that is, the pain and dyspnea, are an unpleasant sensory and emotional experiences with physiological and psychological consequences. There is a very close relationship between these distinctly different sensations, but they share important characteristics also. They both alter the brain and motivate adaptive behaviors. They both involve an array of central neural mechanisms. But we have to remember that pain does not appear to be strongly associated with severity of airflow limitation. So, person with a lesser severity of obstruction may perceive a greater intensity of pain. As in the beginning of this session, I said that it is a subjective perception, so it is not directly correlated with the amount of obstruction a person may be having because of the pathology. Causes and etiology of pain perceptions, which we will be talking about in terms of the anatomical factors, the systemic inflammatory changes that occur, and the musculoskeletal causes or the reasons for it. The anatomy. COPD patients may have an altered sensation to pain either due to protracted central processing of dyspnea and pain. Both have been mapped to activation of common brain areas, including anterior mid-insula, dorsal anterior angulated cortex, sensory motor and somatosensory cortex 2, and medial thalamus. It means that they have common, if we do not remember this fancy words, but it means that they have common centers in the brain. The protracted experience of dyspnea in COPD patients and associated prolonged activation of brain centers may include permanent changes in pain perception. There may be decreased sensitivity to discriminate between different noxious and non-noxious stimuli such as pain and dyspnea at cortical level. So basically, because of the pathology, there are changes at the cortical level, so that the patient is not able to differentiate whether the stimuli is noxious or non-noxious. It's only the things which are causing him discomfort, which is distressing, is causing him pain. And mainly it may be dyspnea or it may be a feeling of tightness, whatever. The systemic inflammation in COPD, how does it affect? Let's see. COPD is associated with marked and prolonged systemic elevation of inflammatory cytokines due to pathology in the lungs. The graph, the figure shows how the inflammatory changes causes an increase in the oxidative stress and inflammatory markers, how this increases the risk of stroke and increases the inflammation further. Hence, it is claimable that this systemic inflammation may contribute to the generation of pain or lower the threshold to pain stimuli. Cytokines like TNF alpha and IL-1 by 3 have been shown to cause thermal hyperalgesia, decrease mechanical activation threshold in C fibers. It can increase mechanical allodynia, which all finally contribute to increased pain and hyperalgesia, especially in neuropathies and inflammatory disease, and COPD being one of the commonest inflammatory disease. So the same mechanism implies there. Macrophage and neutrophilic response central to the etiology of lung disease causes release of large amount of pro-inflammatory cytokines which perpetuate a local inflammatory response and can also impact distal tissues via the circulation. Now the third causes the musculoskeletal factors. Pain is more common in neck, chest and trunk causes include a greater resting hyperinflation, changes in respiratory function, remodeling of thorax associated with COPD, ligamentous strain, excessive joint force, increased work of breathing, postural dysfunction, the location of the respiratory muscles, the primary muscles and the accessory muscles. So because of all these factors or because of the pathology, the hyperinflation, the strain, the use of accessory muscle, increased work of breathing causes pain in neck, chest and the trunk region. Diaphragm and intercostals are overused during the abnormal breathing pattern. We all know that diaphragm is at a mechanical disadvantage and intercostals are weak. They are not able to fulfill the ventilatory requirements. And to compensate that, the accessory muscles, the scaleni, the sternocleidomastoids, they come into play. They are overused and hypertrophied, accentuated by mechanical disadvantage due to hyperexpansion of the chest wall, decrease in available range of motion during ventilation, that is, there is a decreased thoracic expansion, which results in reactive muscle spasm. So these muscles of ventilation, the diaphragm and the intercostals, they are not able to contract and relax in their full range. And so the muscle spasm also occurs in these muscles. Accessory muscles located in neck, that is sternocleidomastoid, scaleni, pectoralis major and minor, and back, that is the erector spinae, levator, costarum, they are overused. A pic of a COPD patient clearly shows the hypertrophy of the neck muscles. Resulting into pain in the neck and back. The COPD cause DOMS, that is delayed onset muscle soreness in respiratory muscles. We have heard this into other skeletal muscles, but does it occur? in respiratory muscles? Of course, yes. In addition to joint pain and muscle spasm, the mechanical disadvantage of inspiratory muscles in the hyperinflated state, which is compounded by increased level of tidal ventilation, makes this muscle prone to overuse injuries and subsequent downs. And it is evident by microscopic injuries in COPD patients. So, diaphragm, like other muscles, is also undergo muscle soreness and loops. The reference for it: another cause for the musculoskeletal pain could be prevalence of osteoporosis in COPD patients, which is about 60 to 70 percentage. And so osteoporosis related vertebral fractures are very common, resulting into severe pain. Moreover, chronic coughing, which is a predominant symptom in this patient, also causes fracture in the osteoporotic ribs and resulting into unbearable excruciating pain. As COPD is the disease of old age, so age-related prevalence of arthritis is also more in such patients, which also causes pain. Headache, which is also a type of pain, can also occur due to chronic hypoxemia. Chronic hypoxia is one of the salient features of COPD. Excessive coughing during exacerbation can cause muscular pain also, apart from the rib pain, which may occur because of the fracture of the osteoporotic rib, which we saw earlier. So, after seeing the pain in the obstructive pathology in COPD, let's see how it occurs in the restrictive pathology. The structures which are involved includes pleura. Conditions may include pleurisy, pulmonary embolus, or a pneumothorax. Another structure is the neuromusculoskeletal component, which includes rib fracture, muscles, costochondritis. Let's see how pleura gets affected. The left lung, which is collapsed because of a pneumothorax. The picture on the right shows pleurisy, that is an inflamed pleura. Causes include pleural infection or inflammation of the pleura, trauma, malignancy. Location of pain could be unilateral or bilateral, often localized. Patient is able to pinpoint that. Onset quality and intensity includes its rapid in onset. Sharp stabbing often catches at a certain lung volume. It is affected by each phase of breathing, that is inspiration and expiration. And we all know that there are two pleuras, parietal and the visceral. And visceral pleura is not sensitive to pain, so the causative responsible factor is the parietal pleura. Aggravating and relieving factors include it's aggravated by deep breathing and coughing, relieved by anti-inflammatory medicines. As I said, that each phase of breathing, each inspiration causes more pain, so patient tends to limit the inspiration, and it is not tender on palpation, but it is persistent throughout. Associated findings include fever, dyspnea, cough, crackles, and the pleural rub. And the pulmonary embolus. Causes include DVT, secondary to immobilization, long distance traveling or so. So this deep vein thrombus, when it gets dislodged in a pulmonary artery, causes the pulmonary embolus and the consequences of it. Location of pain is often lateral on the side of the embolus, but may be central also. It's sudden in onset, sharp pain, and associated findings includes dyspnea, tachycardia, tachypnea, hypotension, and hypoxia, which is most important to notice that it will not significantly improve with oxygen therapy because it is because of an embolus. So unless and until the embolus is there, it will not improve with the oxygen therapy. Hemoptysis, if pulmonary infarction occurs. Unilateral swollen lower leg, which is red and painful, which suggests the DVT. So all these associated findings help a clinician to conclude to a cause whether it is because of an pulmonary embolus or not. The pneumothorax are in the pleural cavity. You all know that, which compresses and collapses that side of the lung. The severity of collapse depends on the amount or extent of pneumothorax. Causes include trauma, spontaneous lung disease, can be iatrogenic, maybe during some other major surgeries, the lung may be damaged or the pleura may be damaged, and then secondly the affected the lungs. Location includes the lateral to side of the pneumothorax, sudden in onset, sharp, and very severe. Depends on the extent of the mediastinal shift. Also, if it is too extensive, it can shift the mediastinum on the opposite side by pushing it. Associated findings include dyspnea, decreased or absent breath sounds on the side of pneumothorax, increased percussion note, tracheal deviation away from the side, and hypoxemia. Now the rib fractures, which we earlier saw, maybe because of osteoporosis or chronic coughing. The lady is troubled with coughing, causing the fracture in the ribs. Cause could be trauma, tumor, fractures, osteoporosis we saw before, iatrogenic surgeries require resection of certain ribs. Location could be a pinpoint tenderness may be present. Patient is able to locate that. Often sudden in onset, and it is aggravated with inspiration and a deep inspiration further. Muscular causes may include trauma, unaccustomed exercise, excessive coughing during exacerbation of the lung disease, may strain certain muscles of expiration, accessory muscles may be affected. Location is quite superficial because of the location of his muscles. And aggravating factors again include certain body movements and inspiration. Relieved by rest, ice, and anti-inflammatory medicines. Another factor for the restrictive pathology pain is costochondritis and the T syndrome. What is that? The causes include trauma, it's a viral infection, location to more or one or more costochondral joints, generalized in onset, it doesn't have a specific onset, non-specific chest pain, so non-specific location and non-specific onset. Coughing, sneezing, deep inspiration, chest movement, twisting of the chest aggravates it, and it can be reproduced at the costochondral junction. Sometimes it is confused with the cardiac pain, the costochondral pain. It may be confused with an angina, so other factors need to be assessed in such circumstances. And it is relieved by anti-inflammatory medicines, ice or heat. So the question arises that why are we all here on a weekend evening? Why are we taking this pain to understand this distinct, unique pain? It will provide a better understanding of the characteristics of pain and its influence on symptoms and physical activity. And this understanding will help to us to design approaches for managing pain in respiratory disorders. So understanding will lead to the change in approach for pain management. A greater appreciation of factors involved in pain perception will be beneficial for designing respiratory pathology specific pain management programs. Respiratory rehabilitation programs can be made more effective in improving health related quality of life, which aims at improving physical, psychological, and social well being of such patients. We know that any rehab program finally aims to improve the quality of life of such patients. Even in our aims and planning, we put the first priority as to make the patient comfortable and gain his confidence. So, unless and until a patient is out of his suffering, if he is not, if his pain, the most distressful symptom is not taken care of, we cannot expect any of our treatment to have its maximum benefit, or we cannot expect a patient's cooperation in our own treatment. If we want a patient's cooperation, we have to understand that his pain or suffering needs to be minimized or gotten rid of. Can changing breathing pattern relieve pain? Because in any respiratory pathology, the first thing to deviate or affect is the breathing pattern. Pattern includes not only the rate and depth of respiration, but also the muscle used. So, if we change the breathing pattern, if we try to normalize the breathing pattern, can it help to relieve pain? Let's see. The pursed lip breathing, which number of times COPD patients assume on their own without we teaching them. And if they have not learned, we try to teach pursed lip breathing for a number of reasons. But how does it? We all know that inhale through nose, exhale a prolonged expiration through a semi-open mouth. That is pursed lip breathing. Use of pursed lip breathing during high intensity exercises decreases dynamic hyperinflation and improves breathing pattern, oxygen saturation, and exercise tolerance in COPD patients who have a reduced peak expiratory flow. Pursed lip breathing during physical conditioning, pulmonary rehabilitation, and activities of daily living is recommended strongly for such patients. This is a reference for it. Slow breathing. But just before we go into slow breathing, let's again recall that patients with respiratory pathology tend to have a shallow rapid breathing, that is tachypnea, and a reduced idle ventilation. Patients with COPD show sympathetic excitation and depression of the baroreflex. We all know that baroreflex is mediated by the autonomic nervous system and it has its main role in regulating the blood pressure. The sympathetic excitation in COPD is mainly because of hypoxemia, hypercapnia, increase in the intrathoracic pressure swings due to airway obstruction, and the systemic inflammation which is there in COPD. It is found that slow breathing can counteract all these changes which are occurring in the body because of the pathology of chronic obstruction. Higher respiratory rate above a characteristic frequency causes sympathetic excitation and vagal withdrawal. Raupach et al. Did a study on this and found that slow breathing is effective in reducing this sympathetic hyperactivity. Slow breathing reduces sympathetic activity and increases baroreflex sensitivity in COPD patients. And finally, the modulation of the sympathovagal balance by slow breathing might have the potential to impact on systemic effects in COPD patients. So, when we try to reduce the rate of breathing in such patient, it not only alters the breathing pattern but also has a systemic beneficial effects in such patients. But important is that they try to use the primary muscles of respiration, that is the diaphragm and the intercostals, and not the accessory muscles, which increases the work of breathing. So diaphragm is so important. There are few ways to strengthen the diaphragm. We all know that it's a thin, a little deeply situated skeletal muscle. So like other muscles, it can be strengthened, it can be stimulated, but may not be directly. But yes, indirectly, it is possible to strengthen the diaphragm. When it contracts, it descends down during inspiration and relaxes during the expiration. We all know that. One is the water breathing technique. Breathing while standing in water, however, requires the diaphragm to overcome a strong, unrelenting water pressure, which is evenly distributed over the abdomen. It's something like wearing a broad elastic garter belt. It's a phenomenal strength training exercise for the diaphragm. The water providing resistance from all sides. And so diaphragm strengthening can be performed. Another simple way could be a book lifting technique. Ask the patient to lie down on a back with knees up. Place the book square on the belly. Take a deep breath. If the whole book lifts up, diaphragm is used. But if it doesn't lift up or it lifts up unevenly, it is not the diaphragm which is being used. In this technique, you can also use certain weight pens. Important is the placement. You have to put on the epigastric region. Try to avoid putting on the ribs, which can inhibit the descent of the diaphragm. The amount of weight should be such that the same amount of epigastric rise with each inspiration should be possible, which was possible without putting the weight, and increase the weight only when patient is able to perform the coordinated unaltered breathing for about 15 minutes with full epigastric rise. And if the patient is comfortable, if he is not using the accessory muscles like sternocleidomastoid for doing so, then you can increase the weight, which will be reflected in after few days of training, which will be reflected in increasing the vital capacity. Diaphragmatic breathing on chronic pain, it helps in relaxation. So good to relax. It also implies the distraction strategy. Concentrating hard on the breathing takes mind away from pain and other distressful emotions. For such patient, when breathing itself is a task, when their full concentration is on breathing, if you teach them a proper breathing technique, their focus changes from breathing, their focus changes from pain to concentrating on breathing, which relieves them of the suffering. It reverses the anxiety symptoms like dizziness, blood vision, and chest pain, which occurs because of rapid, shallow breathing. Improves circulation and facilitates most efficient exchange of oxygen and carbon dioxide with minimum amount of effort. So, whenever in great pain or fear or apprehension or anxiety, practice this in exercise. Take a deep, slow breath. Feel the immediate calming effect, reducing stress and levels of pain, which works, definitely, believe me. Brain makes morphine like pain relievers called endorphins and enkephalins. It's just a state of mind. Think that everything's going to be fine. 1, 2, 3, breathe in. All is well, all is well. You're just going to be fine. They're associated with a happy, positive feeling, and they can relay stop pain messages throughout the body. So, messages convey to the brain, stop the pain, and it works. You've seen all in the movie, right? The Three Idiots. All is well. During diaphragmatic breathing, oxygenated blood will trigger the release of endorphins, decreasing the stress hormones like cortisol and slowing down the heart rate. So even heart is at a benefit. Next technique what you can imply on is staying out of chair, which works in all the ways. Be physically active. Chronic sitting is an obvious mechanical barrier to diaphragmatic breathing. Abdomen is compressed and cannot expand as easily or so far. And when being in chair, it does not get you any form of exercise. We all know that. So everyone is fond of chair. And if working in chair cannot be avoided, like at present, you must be in chair, or when there is a scenario like work from home, online working, take micro breaks. So something is better than nothing. If it cannot be avoided, take micro breaks, but be physically active, which will also help your diaphragm to work in a better way, which will also help your body as a whole. One is fit, one is fine. Stress reduction, too difficult in this competitive world, but there is no option without that. We all would have observed that when we are stressed, our breathing pattern changes. We cannot breathe properly when in stress and in anxiety, right? Different stress relieving treatment therapies. So when we cannot breathe properly, what else good it can do to us? So reduce the stress level by whatever means you can. Respiration and posture have a coupled relationship. We all know that the posture also gets altered in chronic respiratory disorders, the rounded shoulder, the kyphotic spine, which further makes respiration or breathing difficult. So again, it's a vicious cycle because of change in respiration, because of change in breathing pattern, the respiratory muscles are overused, the posture changes gradually, which further makes thoracic expansion difficult, and so the respiration. Breathing mechanics is also altered, so that so postural correction training should also be a part of the program. Should include chest mobility, strengthening exercises. If kyphosis is there, we are not going to detail of what to strengthen and what to stretch, but yes, of thoracic extensors, strengthening should be done, and trunk flexors and pectorals should be stretched. In restrictive lung diseases such as pleural diseases, chest pain is again very common. Pain relieving modalities such as moist heat, infrared, transcutaneous electrical nerve stimulation, or laser can also be tried. Strapping of the painful side. A corset can be prescribed. Positioning of the affected side to prevent the deformity can also be done because tightness further causing deformity, and again the vicious circle of affecting the breathing. So proper focus on positioning should also be made. It should be encouraged to keep the shoulder of the affected side moving, discouraged from adapting the protective patterns. So summarizing that it is an unpleasant feeling. So any unpleasant feeling can also be described as pain, the vice versa. The perception of pain is subjective. Person's report of experience as pain should be respected and should be focused upon. It can either be physical or psychological, so it has no direct correlation with a noxious stimuli. Any respiratory pathology, such as obstructive or restrictive, can cause pain. Remember that lung parenchyma and small airways do not contain vein fiber innervation. The vicious circle of COPD is related to pain and breathlessness. Also important to note is that inspiratory muscles are also prone to overuse injuries and delayed onset of muscle soreness. When suffering from ventilatory inadequacy, instead of breathing with the diaphragm, people tend to breathe with upper body musculature, resulting in cascade of musculoskeletal consequences. So, improve breathing pattern, respiratory rate, strengthen diaphragm, the primary muscles of respiration, stay out of chair, be physically active, improve posture, and reduce stress by any means. I hope that this would have provided a better understanding of factors involved in pain perception in respiratory pathology. Would also help in designing the respiratory pathology specific pain management program, which will improve the physical, psychological, and social well-being, and overall improve the health-related quality of life, which is the sole purpose of any physiotherapist. This pain in respiratory pathology was talked about from a physiotherapist's perspective. Finally, I say that turn your pain into power and be strong enough to face it. Thank you for your kind attention. Thank you.
Thank you very much, Dr. Sweetie ma'am. It was very, very informative and very simplified way you have explained each and every small details. That was really good and very, very knowledgeable session. Thank you so much. Friends, if you are having any question, you can write down in the chat. And we have shared a link in the description box. So you can fill that form and you can prove your presence. Mind well that you can do only one entry. So multiple entry won't be allowed. So please fill the form carefully. Yeah. Friends, if you are having any question, please write in the chat. So, ma'am, as you told that diaphragm itself can be the source of the pain also. So, can you elaborate more over it? How we can diagnose that diaphragm is a real source of pain, or the intercostal muscles are generating pain? How we can absolutely diagnose and how we can differentiate whether it is a diaphragm?
Diaphragm may not be a source of pain directly because it is not a superficial muscle. So it is difficult to conclude that it is the diaphragm, but the consequences of diaphragm being affected causes pain. As I said, diaphragm weakness or diaphragm incompetency causes pain. But yes, if we talk about intercostal muscles, they are superficially situated muscles. If they are weak, they cause paradoxical breathing, the intercostal indrawing. They can be tender on palpation. So, intercostal muscles as a source of pain can be clinically examined and concluded upon.
Uh, there is one question from Rhythm
Yes.
Agrawal. Are good abdominals are essential for good diaphragmatic function?
Yeah. It's a very good question. Actually, it is called abdominals paradox. Abdominals actually are an expiratory muscles and diaphragm is a primary inspiratory muscle. So in a way it means that an opponent is can and an opponent help the other. But yes, the answer is yes, that with a weak abdominal muscle, diaphragm does not get a proper support. If abdominals are weak, the diaphragm does not get a proper support. So it is in a little descended state. Abdominals, if they are slack, it affects the contraction of the diaphragm. Diaphragm is not able to uh, push down as much as it should during the inspiration, which affects the vital capacity. So, number of times during the abdominal surgeries or when there are abdominals weak because of any cause like spinal cord injury, so just providing a corset or improve the tone of the abdominals, the breathing pattern can also be improved. So diaphragms, a good diaphragm for a good diaphragm functioning, a strong abdominals are equally important. And if it doesn't work, we have to try with corsets or with by providing them certain pneumo belts are available in the market. for improving that. I hope it answers.
Yeah. Ma'am, Kolal Kishore is asking about why small airway and the lung do not have pain fibers.
It's God who has made it like this, so there cannot be why for anatomy. It's just that we have to remember that it's not the lung parenchyma and airways that's the source of pain, but it's coming from the other source. Being a microbiome, so we have to understand the cause, the source of pain, and we try to treat that. It's just we have to accept it. Anatomy has to be accepted.
Ma'am, Anjan Sen is asking that breathing exercises are helpful.
For what? For pain relief? Yes, I
Yeah,
would say that if I assume that maybe it's because we are talking about pain. The question should be for pain only. Yes. I say that yes, the breathing exercise, altering the breathing pattern, the respiratory rate, refocusing from accessory muscle use to primary muscle use, they all finally contribute to relief of pain. Because when in pain, this breathing is. So if you change it, if you bring it back to normal, it relieves pain. Just to remind again that the pain perception in such patient is not like the other patients, those suffering from musculoskeletal disorders or neurological disorders. It is because of their distressing feeling of dyspnea or chest binding also. So definitely breathing exercises should be an integral component of pain relief in such patients.
and Preetham Helder is asking that ma'am, you were talking about using TENS, infrared rays, etc. modalities and icing techniques to reduce the pain. So where to place those?
See, it's again a separate topic in itself. Like if you are studying TENS in your undergraduate, and TENS for pain relief will also cover the placement of electrodes. So it should be included into that. Sensational pain, then it is parasensational placement. So I think it's better covered into electrotherapy headings and not here. But what I wanted to convey was that we as a physio also have certain modalities to relieve pain caused by this pathologies.
Ravi Solanki is asking that is there any role of electrotherapy in management of this pain?
I think almost the same. Yes, electrotherapy modalities like laser, like TENS, like IR helps to relieve pain, but again the details of which is not out of the purview of this topic. But yes, we have certain electrotherapy modalities to relieve pain apart from breathing techniques.
Friends, a few friends are having some difficulty in finding the feedback form link in the description box. I just request that if you will refresh your YouTube channel once again, then you will be able to find in the description box. And we are running in the scroll also. So you can note down from the scroll which is in the video itself the feedback link. There is a question from Dr. Paras Gura, sir. Can you describe more about how to differentiate cardiac pain and lung pain?
Okay, it's a very nice and interesting question, I would say. Cardiac pain, which we usually say is an angina, which is mainly caused by ischemia infarction. And actually, lung pain is a wrong terminology. As I said, lung parenchyma does not have pain fiber innervation. So we have heart pain, we have cardiac pain, but we do not have lung pain. So that is the one first main thing. But how to clinically differentiate is the specific characteristics of the cardiac pain along with, and there are specific characteristics of the pain because of a respiratory pathology, which we saw recently in this seminar. But along in this webinar, but along with that, you have to look for the patient as a whole, the other vitals like heart rate, like blood pressure, like the stroke volume, etc. So if it is the pain of a cardiac origin, it will definitely alter the other parameters also. Pain of a respiratory origin will first affect the breathing pattern and the rate, and it will not have any affection on the blood pressure primarily. So assess patient as a whole, and then definitely, I mean, a COPD patient can have an ischemia or an angina, but yes, assess the cause, assess the patient as a whole, look for the vital parameters, and then we can conclude whether the origin is of cardiac or of a respiratory. And then management can be planned accordingly. So to know the source is important for us.
Ma'am, the viewers are so happy with you. So many have put the comment that it is excellent. The way you have explained it is very nice. So many thanks and so many appreciations are there.
Thank you so much. It will be my pleasure if just a little perception of pain can be changed in respiratory pathology, because like people feel pain as just one, they have one insight only. So if that perception can be changed, I will be more than happy. So
Arindam
it's
Banerjee is asking, can you suggest any manual therapeutic techniques which may be helpful to improve the breathing capacity of the patient?
yeah, there are we have release technique, the manual release technique or the MFR for other muscles. These techniques are also available for respiratory muscles, the diaphragm and the intercostal, the MFR for these muscles. But again, the details of which is out of the purview. But the techniques which works on other skeletal muscles, the manual technique, also have an impact on diaphragm and intercostal muscles, because diaphragm is also a skeletal muscle. It is little deeply situated.
Uh, Friends, still few friends are having difficulty in finding the feedback link. I have shared the feedback link in the chat box also. So now there are three places from where you can get the feedback link. One is the description box, another one is the scroll in the video, and another is from the chat box. So from anywhere you can take the feedback link and you can fill the form. Ma'am, Amrit Parihar is asking diaphragm stretching can be helpful for reducing the pain.
It can be helpful, but again, I said because of its location, because of its size, it is difficult to directly intervene on this muscle. To stretch a diaphragm is almost not possible because of its location itself.
Ma'am, Shashwati Kankaria is asking how to relieve pain caused by continuous coughing in the patient.
Okay. One, the commonest thing is the splinting that we do, because we saw that coughing affects in two ways. It can cause muscular strain, muscular pain. It can cause fracture of the osteoporotic ribs or the bones. So continuous coughing, first you have to find out the cause of the coughing. But if the cause of coughing, if at all it is secretions or something irritant is affecting it, you have to take care of that irritant. If it is a secretion, you have to try with different secretion relief, mobilizing and clearing techniques. But before all works, you have to teach splinting to your patient so that the coughing itself doesn't aggravate the pain and inhibit the inspiration. So the cause of coughing, because we all know that cough is a reflex in response to a trigger. So you try to find out a trigger, try to take care of that trigger, and meanwhile suggestive means for it. You can also prescribe a corset for it.
Fantastic. Ma'am, it is almost 1 hour and 10 minutes. I would like to take last question because it's a too long session for you. Question is from Preetham. Madam, why asthma doesn't come under COPD?
Okay. Actually, it is not related to this topic, but yes, I can answer that. COPD, the full form, the chronic obstructive pulmonary disease, and asthma is not a part of it. You are right because of that reversibility factor. Reversibility means that after giving a bronchodilator, if the pulmonary function tests are repeated, then the improvement in the expiratory flow, that is the FEV1, should be by definition it be minimum 10 to 12 percentage or more than 200 ml in FEV1. If we talk about asthma has a good reversibility. It is rather defined as a hyperreactivity of the airways. So when the stimulus, the trigger is not there, the airways are here normal as yours and mine. So the reversibility test is positive in asthmatics. But if you look at the COPD, which is a chronic obstruction, despite giving a bronchodilator, if you repeat the PFT, there is an improvement, but not up to the start of 10 to 12 percentage of pre-bronchodilator stage. And so, by definition, COPD is classified as an irreversible obstructive disorder, and asthma is reversible. That's the basic difference. So, clinically, seeing a patient, there may be an overlap between the two, which can be confirmed only after a proper investigation like pulmonary function test.
Wonderful, madam. Thank you so much. There are so many other questions, but I think the time is running
Maybe in the
by.
next session, hopefully. Yeah.
Yeah. So we will
But I'm
definitely
happy
take.
that people have questions.
Yeah, please, ma'am.
Yeah. I'm happy people have questions because curiosity is needed for knowledge. So
Yeah, of
good.
course. And question are to be asked to those
And
who
thank
can give answers. So that itself proves that they are feeling that you are the person to ask the question and get the proper answers. That's why they are asking. Friends, thank you so much
I
for so vibrant involvement.
I
Uh, yes,
thank you, sir, for providing this platform just to be a bridge between the audience and me. It's an honor and a privilege, and I enjoyed the session. Thank you so much.
thank you very much.
Thank you.
Thanks, ma'am, for all this knowledge. We have
Thank you,
learned a
sir.
lot from this. And thank you, viewers, for joining us in this good number and participating throughout. We really appreciate your efforts. And we'll make it a point that by tomorrow
Yeah.
evening, you will receive the certificates. Thank you so much, everyone. Good night and wish you a wonderful weekend.
Happy weekend. Yeah. Good night and be safe and enjoy. Have a happy weekend. Thank you. Thank you.